Hey, welcome everyone to the PFCC Partners August workshop. Today, I am very excited about our topic, and I know all of you are as well, which is why you're here. We had a lot of interest in partnership in the ICU communication. So I'm very excited to welcome our presenters today, Dr. Dong Chang, Dr. Glenna Chang, and our very own Libby Hoy in just a minute. Before we get started, really quick Zoom tips. I know we all know a lot about Zoom at this point. So, but if you do have any questions today for our presenters, please put those in the chat box. And we will get to them at the end of our session. During the session, if you could please stay on mute, and we'll have plenty of time for Q&A at the end of our session. I also want to thank everyone who registered for all of the great questions that you put in the registration. So we do have those as well, and we'll be addressing a few of them at the end of the presentation today also. During the Q&A, if you do have a question that you would like to come off mute to ask, you can click the raise hand button. I think I need to update this slide because Zoom has updated a little bit, but you should be able to find it by clicking the reactions button on your Zoom toolbar or going to participants and then raise hand. Okay. And before I pass it off to our presenters today, I wanted to introduce our organization, PFCC Partners. We are a patient-driven organization, and all of us here at PFCC Partners serve in the role of patient family advisor, anywhere from our local hospitals to national partnerships. We all utilize our experiences as patient family advisors to support the partnership of healthcare providers, patients, and family caregivers, because we know that the best possible health outcomes happen there. Our vision is to reinvent the healthcare industry so that all stakeholders continuously partner with empowered patients and families as a resource in the co-design of programs, policies, and quality improvement activities. I am Lindsay Galley. I'm the Director of Education for PFCC Partners. Our organization also fully supports and facilitates the Patient Family Advisor Network. This is a network of, or a community of highly engaged patient family advisors from all across the country. It continues to grow every day. And we also grow each of the PFA network members through connection to the community and peer learning among other patient family advisors. Also growing everyone's competencies through skills exchanges. And also to grow their skills to partner in co-design of effective healthcare systems, processes, and policies across the country through a wide variety of engagement opportunities. And so with that, I will now pass it off to Libby Hoy. Libby Hoy is the founder and CEO of PFCC Partners, and will be kicking off our presentation today. Libby?
Thank you so much, Lindsay, and thanks to all of you for taking an hour out of your very busy schedules to join us today. I'm truly honored to have had the privilege of working with Dr. Chang and Dr. Chang to deliver this project during such an extraordinary time, with both of them being very active in the intensive care units. As you can see, Glenna is joining us from her intensive care unit today. So again, my gratitude to the two of you, and just excited to share our project with you today. I will mention, we'll go ahead and PDF these slides and they will be available. But in addition, what we're really excited about is the outcomes report that we're putting together. I think that you'll all find that very informative and give even greater detail than what we're able to do today. So you'll get that in, you'll get both those items in follow-up. So the National Academy of Sciences awarded us a Catalyst Award in September of 2019, so just a bit before the pandemic. And you'll hear more about the focus of our project, but we have been so grateful to, again, partner with Kaiser Permanente in Southern California and Los Angeles County Department of Health Services for this project. The research reported in this publication was supported by the National Academy of Sciences, the Building Capacity for Science Communication Partnership Awards, with funding from the Rita Allen Foundation and the Kavli Foundation under award number 2001-0857. There we go, got that recorded. All right, we've been so honored to be very supported by the National Academy of Sciences. I will say they've been extraordinarily flexible with us through this time, and really grateful for their guidance. So the focus of these Catalyst Awards were really to build the capacity for science communication. So how do we bring the evidence base into sort of the real world and communicate that effectively? So with that, I will move on to the next slide. Thank you so much. So you see the gears, which are part of the PFCC Partners logo and really central to the way that we work. And that's because we truly believe that to design solutions in their healthcare systems, we really need all perspectives. It's not a matter of patients and families having the right perspective and telling anybody what to do. It's really bringing that additional perspective in with both healthcare administrators and organizations, as well as the clinicians who are providing the care. Together, we really make a very strong unit. And our project was really exemplified that approach. And so with that, I will pass off to Glenna to introduce herself. Do you want to come off you and or no?
Apologies.
No problem.
I am Glenna Chen. I'm one of the ICU physicians here at Kaiser Permanente. I'm based in the South Bay Medical Center, and very honored to work with Libby and Dong on this project. And Dong?
Thank you very much. So my name is Dong Chang, and again, very privileged to be involved in such a really interesting and collaborative project. Just as a way of introduction, I work at Harbor UCLA Medical Center, which is one of the county hospitals here in Los Angeles. And I also have an appointment in the UCLA School of Medicine as a health services researcher, but at my core, I believe myself to be an ICU clinician. And I think you'll hear that come through as we talk a little bit. So if we can move on to the next slide, I have the pleasure of starting to introduce our project to you. And I think we'll begin by telling you a little bit about the healthcare systems that are involved in this project, because I think that is one of the unique characteristics. So I work in the Los Angeles Department of Health, which is the second largest public healthcare system in the United States. It serves a large number of predominantly indigent patients. It is racially and ethnically diverse, with a lot of socioeconomic disadvantage, as you can imagine. And it really is one of the major areas here in Southern California where we try to serve those patients that might not necessarily be able to help themselves well. Glenna Chang is a part of Southern California Kaiser Permanente, which I'm sure many of you have heard about. It's kind of the big giant healthcare entity here in Southern California. It is one of the nation's largest healthcare plans, serving almost 5 million people here in Southern California. And in my opinion, an extremely innovative and aspirational healthcare system for us, certainly in DHS, to try to model ourselves after. So a really interesting healthcare systems as a part of this project. If we can move to the next slide. So let me describe to you as clearly as I can what our goal was. As Libby mentioned, this project and our grant is about improving communication. And where we wanted to really focus is in the intensive care units where the sickest patients are hospitalized. And I think you can probably guess why it would be important to communicate well in the ICUs. We make extremely high stakes decisions about very serious problems. And in fact, having good communication so that patients and family members understand what's going on and what treatment options exist, and physicians and nurses and other healthcare professionals understand the preferences and the values of the patients and the families would be extremely important. And so this is an area ripe with opportunities for good communication, but also misunderstanding. And so we really wanted to dive into that. And I think we can all probably understand that oftentimes communication is relatively straightforward when things are going well, but it's actually when things are dire, when patients aren't responding well, or when they're extremely sick, that the communication, the ante is even higher. We have to communicate even better. And so over the course of this project, what we wanted to really focus on was those situations when the communication is going to be the most important. And in particular, those are times when we're not really sure whether the ICU treatments are going to be helpful, when we have to talk about bad news, when we have to even talk about end-of-life care. And so you're going to see over the course of this project us describe that as one of the core themes that we're going to work on in communication. So it's not only ICU communication, it's a particular type of ICU communication, talking about bad news, talking about maybe even whether treatments might or might not be helpful. So if we can move on to the next slide. At this point, there are many stakeholders involved, and I think I'm going to go ahead and hand off to Glenna to discuss a little bit further about who our stakeholder groups are.
Thank you, Don. So like Don described, we wanted to make sure that everyone had a voice or a seat at the table, and most importantly, highlighting what patient and family caregivers see as necessary as improving ICU communication. So in addition to the key group of patient ICU caregivers, we wanted to include in our project ICU nurses, ICU physicians, and most importantly, we needed to recognize that we couldn't make these changes as frontline people on our own. So we had to include various healthcare administrators and various other kind of people that make our jobs better in the ICU to achieve patient communication goals. Next slide, please. So what was our purpose in this project? The purpose of our project was to, number one, improve interpersonal and group communication. And again, we all know that communication is not simply between two people. It's multiple ICU physicians, multiple patients and their family members, and specifically focusing on those with advanced illnesses and family, because that is, like Don described, where things get really sticky in terms of trying to determine the right goals of care. So the purpose of our project was to, again, improve communication, and through what we visualized initially as a catalytic activity, we wanted initially to have a full day workshop with all these key stakeholders in one room, from the various patient family caregiver groups, and then including people from the LA County and the Kaiser Permanente healthcare systems. And our hope at the end of this project was to then establish a network of engaged stakeholders so that we could further work on ICU communication and provide a summary report to the various stakeholders. Next slide, please. So then the pandemic hit, so we had to shift our goals, and we talked about the dangers of being in one room of 50 plus people, not only knocking out ICU physicians and nurses, but also putting patients and family caregivers at risk. So we decided to transition to a virtual meeting since we're all Zoom experts now. And we wanted to make sure we decrease the burden of participation, because we knew that everyone at every level is very busy as a result of the pandemic. So we came up with the alternative format, and then also decided we should recognize that the impact of COVID. Our intent was not initially to focus on COVID, because COVID didn't exist when we applied for this grant, but then we wanted to make sure we recognize the reality of how communication has changed as a result of COVID, including the broader use of technology with communication. Next slide, please. So our aims in this new kind of pivot plan was to document communication patterns in ICU during the pandemic, and then identify opportunities to improve communication, and then again to end up with a summary document so that we can share with various healthcare systems. So in order to do this, and in order to avoid, again, having 50 people plus in one room, we started with the first objective, breaking it down to, again, getting the most important voices engaged. So we invited patient and family caregivers, and the way we did that was we started, and many of you may have actually been recipients of the survey. We started with a survey just trying to assess people's experiences as a patient or family caregiver with the ICU. And then with that survey, we included a question about whether people were interested to actually participate in a focus group. And from that, we gathered our key patient family caregiver group to survey. And then from that focus group, we then moved on to 2 additional focus groups you'll see in the gray boxes. So the second objective, to engage ICU physicians, we had a group of just ICU physicians from the Kaiser Permanente and the LA County system. And we shared the results of what we found with the patient caregivers, and then used that to springboard to the focus group with the physicians. And then we did the same exact thing with a group of ICU nurses in the LA County and Kaiser Permanente healthcare systems, again, sharing the thoughts and findings from the patient group, and then using that to stimulate discussion amongst the nurses. And then lastly, we achieved our third objective in the multi-stakeholder group by doing a big Zoom meeting, again, sharing the patients and caregivers' thoughts. And then we actually used a paper that Dr. Chang published with the LA County system about something which will go on a little in more detail about time-limited trials, and using that as a tool to improve education. And then from that initial introduction of that tool, we then broke our group down to 3 smaller groups, including, again, patient caregivers, physicians, nurses, and administrators, in order to then come up with eventually our findings. Next slide, please. So again, this slide summarizes 3 focus groups. And so again, I'll try to make this a little easier to read, but the top gray boxes are what we got from the patient and caregivers, what they shared with us. And then again, we reflected those findings to the nurses and physicians, and that's what our findings are in blue. And then we'll summarize the yellow at the end. So the way we did the patient and family caregiver focus group is that we came up with 4 questions about expectations of communication in the ICU, and what how preferences and how knowing an individual was important. And we also asked their experiences with consent and about information about letting go. And so what we got was that the patient and family caregivers wanted, it doesn't sound like much, but they really wanted daily updates, which we realized from the frontline physician nursing group, I guess we weren't doing a very good job at that. So one of the first asks was that patient family caregivers be provided daily updates about both short and long-term prognosis. And then the next gray box, one of the other recurrent themes we heard was the importance of getting to know the patient as an individual, so that we could align treatments with personal preferences and priorities. And then the last box, one of the, important themes we gleaned was that the information that the healthcare team was sharing with patient family caregivers needed to be clear, realistic, and consistent. Again, none of these are earth-shattering, but again, I think it was really important for the nurses and the doctors to hear that, the fact that, these were basic expectations, which we thought we were achieving, were not, I think gave us pause to do a better job. So when we shared those things with the next focus groups with the physicians and the nurses, we asked them what they thought they could do to better achieve the things that we thought there were gaps in from the patient and family caregiver groups. So the physicians and nurses came up with a realization or a understanding that they needed to focus on the big picture of when they're updating and communicating with patients and family caregivers. They also recognized that there's a definite limitation in time, which made it harder to communicate, or not harder, but made it less ideal because of the time constraints in balancing patient care duties and communication with family. And then we also talked about, if we allowed other people to help the physician and nurses to communicate, were there pros and cons of that? For example, having a nurse dedicated to just communicating the outcomes. Were there good things about that? Were there bad things about that? Obviously, there are a lot of pros and cons. In the next blue box, when we talk about the importance of knowing patients as individuals, the physicians and nurses reflected, and again, I think part of this was the effects of the pandemic, that it's much easier to focus on the disease. But it's actually, I think we all recognize as frontline healthcare providers, and it's necessary to understand the person. But a recurrent kind of concern was the mental health toll of the price you pay for trying to get closer to someone, to know them as an individual. But understanding the importance that knowing the individual provides guidance and connection to the care, and so that everyone feels much more comfortable with care. And then with regards to the last box, when we talked about information being clear and realistic, physicians and nurses saw that there was a gap between what was being said and what was actually being understood. So I think one of the important things was that making sure physicians and nurses check back with patients and family caregivers, what was being told, being understood. So, asking for kind of a feedback and making sure that the family understood by seeing what was going on, what the issues were. They also recognize that there's a big burden on family for decision making. We heard a lot from the patient family caregivers, this sensation of guilt when they're asked to consent or to make decisions, even though that's probably the onus that the physicians need to burden. The physicians are the professionals who are guiding the decision making. So we recognize that was a big gap. So we want to make sure that we don't put undue burden on patient and family members. We also want to make sure that goals and boundaries for discussions were really important, so that we could help patients and family caregivers have realistic goals and realistic decisions to make, rather than feeling that the whole world, the whole responsibility was up to patient and family caregivers. So from those three focus groups, we decided that the main take-home points were that we need to start talking early in the ICU, communicating early, setting expectations, being consistent, and following up regularly. I think those are, again, very, very simple, but very difficult things to achieve sometimes in the chaotic ICU environment. We also recognize that there's really important to know the individual with regards to values and preferences to help decision making. And then also, in order to communicate better, we need to also promote the concept of shared decision making, and to always make sure to check for understanding, make recommendations, allow time for adjustment, and then again to set goals and boundaries to medical care. And the next slide, I'm going to hand back to Dong.
Great, thanks, Glenna. I will say that the focus groups were amazing for me to both facilitate and learn from. They were so rich with information. And I think on this slide, we're showing you just one of the topics that we talked about. As we mentioned, we talked about a broad range of topics, but eventually we wanted to get to this idea of how do we communicate best when things get a little bit challenging in the ICU, especially when ICU treatments aren't working and so forth. And what we're showing you here is just some of the themes that emerged when we talk specifically about this concept of how should we communicate when we need to let go, or when we recognize that treatments aren't having their intended benefit on our patients. And you can, I won't go through each of them in detail, but you can see that the themes that Glenna talked about kind of resonate here. The information needs to be clear and consistent. We have to be empathic. We have to communicate in a passionate manner. The clinicians talked about making sure that we have consistent communication across different teams, how we need to find the right family members that are both understanding of the medical issues, but also appropriate members and leaders within that larger family group for us to communicate with and so forth. So some of the themes that are outlined here, you'll be able to review in greater detail when we give you the summary paper. But I wanted to at least give a sense that we're now heading in that direction of, okay, how do we communicate when we are potentially in a situation where ICU treatments might not be helpful? And starting with the next slide, I think I'm going to talk a little bit about why that's important to deal with. And I think, you know, in the past year with the COVID pandemic, it has certainly come to light with the ICU clinicians that we have major limitations in what ICU care can provide. We knew this before, but at no time is it more recognizable now that despite our medical treatments and our advances in technology, unfortunately, we oftentimes run into situations where despite our best efforts, the ICU, the invasive ICU treatments will not be able to help the patient recover to the extent that they would like to recover. And oftentimes they would also pass away in the ICU. And we have to be realistic about that. But on the other hand, we have to communicate that well so that everyone's on the same page. And why is this important? Well, this is important for many different reasons, including the fact that ICU treatments are oftentimes invasive, they're uncomfortable, and for a lot of people, they lead to health states that would be undesirable for them. So we really have to recognize what the treatments are doing, what the likelihood of recovery is, and how best we maneuver through that situation. If we can go to the next slide. If we're not careful with this, if we just indiscriminately provide tremendous amounts of care without really thinking about where are we going and what would the patient and the family feel would be the appropriate care for them, we can really lead to a situation where we deliver medical care that prolongs pain and suffering without long-term benefit. It certainly increases the caregiver burden, just watching their family members go through this very, very difficult time, and these invasive treatments could be traumatic, as you can imagine. Perhaps most importantly, it may be misaligned with what the patients would choose for themselves. In the ICU, we're oftentimes in a situation where patients are unable to communicate, unable to choose for themselves, so we have to guess. And at least some of our medical studies would suggest that a lot of the invasive care that's delivered during this time, if patients were allowed to speak and think about it beforehand, they really wouldn't choose such invasive forms of care. And unfortunately, because of the limitations of ICU treatments, we are oftentimes in a situation where despite delivering that tremendous amount of invasive treatments, it's unlikely to improve long-term outcomes. Now, in the medical literature, we're going to call this non-beneficial treatments, and you may see that word, those words thrown around a little bit. And that's this theme of medical care in the ICU that we're referring to when we say non-beneficial ICU. Go on to the next slide. So as Juana mentioned, prior to our multi-stakeholder group, the partnership, we were trying to decide, well, how do we make this the most effective? And we decided that one of the ways to do it, because our long-term goal is to really try to create something that would improve this process in healthcare systems, was to at least use as a foundation an intervention that already we've studied a little bit and may have a little bit of feet for us to walk with. And so, as mentioned, this idea of a time-limited trial was something that we were working on in the Department of Health Services in Los Angeles County. And this is a communication and care planning approach. And I'd like to take you.
Don, can I interrupt? You're muffled.
Is this okay? Is this better?
Yeah, just speak up a little because you're muffled.
Okay, sorry about that. So I'd like to take you a little bit through what a time-limited trial is. And basically, the easiest way to understand it is it's a communication strategy that really tries to define between clinicians, patients, and oftentimes the surrogate decision makers working on behalf of the patients to use medical therapies, such as mechanical ventilation, being on the breathing machine, just for a defined period of time, and to really carefully observe what happens as a result of that. Are we seeing the improvements that we want to see, or despite that, is the patient getting sicker, not responding, and really use outcomes that we think are good surrogates, good measurements of that sort of improvement, and use that as the basis for further decision making. This has the effect of really getting on the table, what would the patient prefer? What would the family think about these sorts of outcomes? What are the interventions that may or may not help? And really focuses on the priorities and values of the patients. It is iterative decision-making, so it provides good prognostic information. And I think it just allows some time for adjustment to get to know the ICU, to get to know the staff, to get to know the treatments, and really experience a little bit what the patient is going through. And in doing so, I think it refines our ability to prognosticate, and it hopefully builds consensus about what's happening in the ICU. So that's what we're referring to when we say a time-limited trial. And as mentioned, there was a study that we published that used this as a communication and care planning tool. And what we found was that it was effective in several realms, including the quality of the communication and the healthcare that's delivered as a result. So we use this as kind of an initial, well, this is something that we've done. Let's see if we can improve on this a little bit during our multi-stakeholder meeting. So if we can move on to the next slide. So this is a breakdown of some of the participants that we had in the multi-stakeholder meeting. You can see that there were 5 patient family caregivers, 7 members of the ICU staff, 6 members from administrative staff, and we're really talking about high-level administrators, chief medical officers, and so forth. And then we had some other people involved, such as palliative care and social work and so forth. What we want to give you a sense of is that this truly was a multi-stakeholder representation. And we wanted to keep the numbers at around this count because of the type of format and the discussions that we wanted to have. We felt like this was an effective number to promote discussion and hear all voices. Let's move on to the next slide if we can. And so this is a breakdown of some of the insights that we had from the multi-stakeholder meeting. And just to remind you, there was a richness in the information, and we're trying to summarize a little bit based on some of the key things that came out about our time-limited trial intervention, because we feel like this is emblematic of a type of tool or our intervention that we can develop in healthcare systems. So the group decided that it's a nice framework in the sense that it kind of puts into systems the requirement for early communication, the expectation for early communication and shared decision-making. It promotes clear communication because we really are talking about these are the things we should focus on. These are the treatments that are on the table right now that the patient may benefit from. And I think it really takes some of the ambiguity away. But as you can expect, there were things that were definitely not addressed by this intervention. And this is where I think we really did a lot of learning. So one of the big themes that came out was that this intervention really doesn't address educational, cultural differences. In my healthcare system, where we serve many indigent patients of different races and ethnicities, this was eye-opening. This was huge. We really need to work on that. It really doesn't address things like, well, it does give you content in terms of communication, but communication is so much more than that. How you say things, the way you say things, the compassion that you show wasn't necessarily addressed. We also need to take into account other things such as how do we ingrain this into a healthcare system, make this the norm, really use the insights of our administrators and healthcare leaders to make this kind of the standard practice. How do we actually get that going? And I think those are some of the major things that were emerging. Again, we're going to give you a more detailed written summary of everything that came out for your review. But what I want to give you a sense of is the multi-stakeholder meeting was really used to kind of dive down into the weeds and figure out how we can co-design this for improvement, co-design this so that it actually gets well entrenched and implemented into healthcare systems. And those were some of the things that, that really provided some insight for us. So if we can move on to the next slide, I'll hand it over to Glenna to finish up.
Great, thanks, Dong. So after all these focus groups, Dong, Libby, and I sat down and tried to figure out what we're going to do with all the great information we got from our various stakeholders. So our intent is to develop a set of interventions to improve care. And we need to commit to co-designing, which we, again, I think all of us involved in the different focus groups. So Dong, Libby, and I saw the importance of co-designing, as I think the more input we have from everyone involved, in the better we can make a successful intervention. So how do we do this? How do we create spread and uptake? That's the big question. How do we motivate the healthcare team? How do we motivate patient and family caregivers to interact in such a way? One of the important things we need to do is figure out how to address the system level changes, because this is something, it's nothing new, but I think it's a different mindset and how to influence. And like Dong said, how do you get the buy-in to support the intervention? It's important because again, it takes time, it takes intent. And lastly, we need to empower everyone who's on this call, everyone who walks through the hospital doors, all of ourselves, to empower patients, family caregivers to anticipate these communication needs, not only in the inpatient setting, but in the outpatient setting. Because I think we learned from a lot of the frontline healthcare providers, as well as patients and family caregivers, how important it was to start that conversation early on, rather than focusing solely on interventions in the ICU. So that is our intent. We still have a ways to go, but we're just really proud that we survived the pandemic. We actually got a project that came out of this, and we have a paper which Libby will we'll talk more. We'll share with you at some point. But for a while there, we weren't sure how far this grant was going to go. So thank you guys for allowing us the opportunity to share with you. Libby, I'll turn it back to you.
Thanks so much. I'm glad to see that we've got ample time to take questions, because I know we got a lot of good questions through the registration. And as Glenna referenced, yes, we are putting together a comprehensive outcomes report, and happy to distribute that to anyone. So it seems like we've got a couple of questions in the chat. Mary, do you want to come off mute and kind of give me a little more context for the question?
Yeah, hi everybody, Mary Schramke here. I think one of the things that came to mind about coping strategies, where that's coming from, is that I know the team talked about giving folks information, but a lot of that information is not the best news, and can put them in a mental state that, where they're not really able to learn. And there's also, I think you also mentioned the guilt of having to make take people off life support, that kind of thing. So, I mean, there are supports for family members that are out there, but I'm just wondering if the team is thinking about ways to include in the package, of educating patients that, they really do need to cope, they need support, and it's okay to ask for help, that kind of thing. I don't know if that helps.
Yeah, no, I really appreciate that question. And I think it's an important aspect that needs to come through. And I think we heard it on our focus groups as well, with many family caregivers, of the strain that role creates, especially during COVID, when all of the communications had to go virtual, and and that was very difficult for everyone. So it's a really good point to consider including right into those conversations, acknowledging the difficulty of the role of the caregiver, and providing those supports. It's great insight. Thank you.
Mary, thank you for that question. If I can just piggyback on Libby's comment, I think you are absolutely right that there is a tremendous.
Dawn, you guys speak up again.
Oh boy. Okay. Can you hear me better now?
No, you're still really, it sounds like you're far away.
Oh gosh, I'm so sorry about this. I don't know why I'm having this problem today. I've been working on Zoom through this mic the whole day, and so far it hasn't been, but okay. So I will practically yell if I have to. But Mary, I wanted to actually say it's a wonderful question. It actually is the reason. So your comment reminds me why it's so important for us to partner with patients and family caregivers, because I'll tell you that having thought of an intervention like a time-limited trial, while it's obvious, there was this focus on how do I get my colleagues, the physicians, to speak in a way that would resonate with families, that would be compassionate with families. But we just didn't have the lens and the perspective to say, what other things do we need to do to take care of them well? And I think we wouldn't be able to think of that on our own. But I think the partnerships that are developing, the opinions that we can get from people who have really gone through this will really help us come up with the appropriate interventions and the appropriate support systems that will address this important problem, because it is a problem. We have a lot of literature that suggests that anxiety, depression, PTSD is prevalent in our family members after they have this sort of experience. It's just that no one's been able to really address it well. And I think this positions us to finally be able to start to think about those problems and come up with solutions, or at least ways to improve it. So thank you for your comment.
Yeah, I think that's, oh, I'm
Go
sorry,
ahead,
Libby. I just wanted to add, I think that's a really great comment, because I think anytime we receive bad news, it doesn't matter how nice someone says it, it's still bad news, right? I think it can be delivered better. And I think that's why, for me, it's important to be prepared. And at Kaiser Permanente, they have a great program. It's not perfect, to start as an outpatient, to start before people get sick, and then to kind of ramp up, these discussions when people are getting sicker, to sort of prepare yourself as a patient and family caregiver. But I think you're absolutely right. When you don't have the support to deal with just the shock of the kind of difficult decisions that you have to make, I think it makes decision making much more difficult. So again, thank you for bringing that to our attention.
Yeah, these are great thoughts and continue to expand our thinking. Rosie, I think you have your hand up, and I saw your message in the chat too. And I'm sorry that it's bringing up bad memories for you, but I'm also interested to hear your comments as well.
It's not exactly bad memories, but it is interesting, because when I had been in ICU a few times, but one time I was in ICU for quite a while, and I was in a coma. And when they put me, when I came out of surgery at that point, David was told that they didn't know if my kidneys would, or my memory, my mind would be normal if I survived. And David knew, and he and I had talked often about the points when just let me go. When and one of them was my mind. If my mind is gone, let me go. And so he knew that was one of the concerns. But the other things were that things would happen, and he would say to the staff, I know Rosie, this would bother her. He came in one day and I was tied down because they thought I was trying to pull my tube out, but what it was they had bandaged me across my chest, and I was itchy because I'm allergic to bandages, and they didn't know that. And so he said, first of all, she'd be very upset if she was tied down. And secondly, it's not because she's trying to pull a tube out, it's because she's itching because you have these bandages on her. So, it was, and I remember coming out of the coma and then being put eventually into a regular room. And I remember one day my physician coming in and saying to me, how are you today? And I said, I had a rough day yesterday. All of a sudden it hit me up how close I came to death. And I said, I spent a good part of the day crying. And he said, that's okay, Rosie. I've scheduled crying for you on Saturday. He said, because yes, this has affected me too. And I think that honesty that he had to say, your experience and the relationship you and I have, it affected me badly too. And yes, I had a scheduled time to cry, and I've scheduled it for Saturday, because it is hard in that mental experience for everybody, and family members, the person, when they get better, realizing how close to death they were. So I really appreciate the work you're doing, and I think it's valuable. It's so valuable.
Thank you so much, Rosie. If I sound like I'm yelling, it's not because I'm yelling at you. It's because I've been instructed to speak loudly. But several things that you said are amazing and resonate with me. So as an example for how we would approach trying to improve communication, Rosie, with your husband, for instance, who was with you in the ICU, and in reality, as ICU physicians, we would oftentimes be communicating with your husband in a time when you were in a coma. And it is such important information for us to know that Rosie prioritized her mental capacity, because that's what we would follow each day in a time-limited trial or in a good communication setting, because we know that's the most important thing to you. And I wouldn't have known that up front, but really having that careful communication really guides us in terms of being able to understand what's important for you, how your ICU course is doing, whether we're going to get the expected outcome that we're all hoping for. And so, you know, I think this is just a really nice example of how making that clear is really important, not only for our patients, but for our entire care team. The other thing that you mentioned, which I think is phenomenal, is this idea that what you remember about the communication is the empathy and the compassion that the physician had. And, you know, one of the themes that we had was communication is not just words, right? It's actually, how do you deliver that message? Do you show that you care? I see comments in our chat that kind of reflect that as well. And I think, again, that's such an important lesson for us to learn and try to move forward into the culture of our healthcare systems, because, you know, if that's what you remember, that's what's the most important. That's what we must convey, and we should really hold ourselves to that task. So I appreciate those comments very much.
Yeah, I do as well. Rosie, thank you for always sharing your experiences in such an impactful way to expand our thinking. What I was thinking about when you were talking is, you know, I'm an eternal optimist, and I think that most people go into healthcare because they really care about people and they really want to make people's lives better. And so I kind of go to the system level. How does the system support clinicians in the intensive care unit to take the time to be compassionate, to be empathetic? How does the system ensure that you're getting the same information from clinician to nurse to anyone else involved in your care? So this is just what I was reflecting on as you were speaking.
And Libby, that actually kind of brings a question that is one in the chat and a few that we got through the registration. It's how can administration or the system, well, with Joe's question in the chat, how can they be kept involved to eventually integrate findings throughout the culture of the organization? And then on the other side, how can administration best support to kind of the mental health crisis that's been brought on to ICU frontline staff to learn how to support them as well? So just some reflections on kind of the administrative support that comes into all of this.
Yeah, I'm going to take a first stab at it, and then I would love to hear from Dong and Glenna. But in my mind, that was essential to our project and bringing in the administrative staff to the multi-stakeholder meeting. And I have to say, I was really impressed with the level of commitment and the folks that showed up from these two health systems. So I think there is a recognition that we have to have leadership involved in order to make the systematic changes that we need to have in order to support really high quality communication in the ICU. So I think it's absolutely essential. The mechanics of it, I think, is something I'm reflecting on, a conversation Glenna and Dong and I had not too long ago after the multi-stakeholder meeting, thinking about, you know, what are the mechanics of that? How does leadership put this into action? And so I think there's more to be explored on that front. But yeah, I think that was an essential piece of bringing the administrators to our multi-stakeholder meeting. But Glenna, Dong, did you have other thoughts?
I think I would just echo what you said. I think we were very intentional on who we asked to participate from the administrator side when we had the multi-stakeholder group. Dong and I pretty much went straight to the top and asked people, because we recognize that patient-centered care, again, that there's such a focus in the past 10 years on patient-centered care. And I think we're not doing as much as we can. And so with the buy-in from, you know, the big guns in the healthcare systems, I think it does trickle down. And I'm impressed by, again, especially in the middle of pandemic, asking them to give us, you know, 75 minutes of their time to just hear out, you know, patients, hear out the patient family caregivers, hear out ICU nurses, physicians. I think it was really important for them to hear. And I think that's where it starts. And of course, you know, now we have to make something more tangible, and that's harder. You know, it's easy for them to just participate in a meeting, but I think there is a very much a recognition of the importance of trying to do better and to focus on the patient and family caregivers perspective, and to look at things from that lens. So again, thank you guys for, again, recognizing, again, the importance of involving that. It's not just a frontline or a patient caregiver issue. It's something that goes higher up.
Well, I think it's a complex process to change a medical system's culture, but I think the best way to approach it is probably have the right timing. And I do think in light of the COVID pandemic, this is an issue that has really come to surface as something extremely important. So everyone is engaged. And I think not just focusing on the leaders, but focusing on everybody involved is probably the right approach. So leaders are going to have one lens, ICU directors are going to have another lens, frontline clinicians are going to have another lens on things. And I think our goal would be to actually try to target everybody. So as an example, when we did our project before and how we might consider moving forward is that, well, one of the priorities of the frontline clinicians is how much time is this going to take? Are you going to give me the tools and the experience and the training to do this well? For the ICU director, it's going to be how am I going to create that experience? For the leader of a healthcare system, it might be what would be the end result of all of this. And I think really recognizing each of the needs across the levels, delivering something that really promotes the priorities for each of those people is going to be something that's important, because you know it can't be top down, it can't be bottom up, it has to be just full engagement across the board.
I love that. And I think that, you know, the value of having all of those perspectives in the same meeting with the same question in front of us and the same challenges and the same dilemmas, I think is, it was a really robust way to go.
Okay. Thank you. All right, Dr. H.
Yes. Just want to jump off of what Glenna just said about patient-centered care. Early on in the presentation, on one of the slides, the words that jumped off the page for me was for the clinicians and the nurses, said the pros and cons of outsourcing communication. That doesn't jive with me at all for patient-centered care, but I don't know what you were thinking and in that, and connecting that to what you said about ICU care being too much, and yes, too much care leading to harm, patient harm, and family harm as well, because it's a whole team effort there, and harm to healthcare providers, because we see the, you know, how all of this pandemic has taken its effect. I just heard yesterday in New York City, I believe, that 1/4 of the nurses have left the profession. So if you could just talk about what the thinking was on the outsourcing communication that was on the slide.
I can jump in. So thank you for your comments. First of all, I think that the outsourcing we mean is where there, for example, we have a life care planning nurse in our ICU, and sometimes she'll do the groundwork, for speaking to families before a physician sits down and has a conversation for the family. So we were thinking, are there other systems where that's available? Is that someone, in addition to the physician, has a responsibility to reach out to the family? Not saying that the physician doesn't speak to the family, but provides additional support and information. And I think the reality is it's a time limitation. If there are 20 COVID patients in the ICU, the physician is the only one who can manage the ventilator, right? But the nurse may be able to talk about the same issues a physician would if the physician could address all the end of life issues for patients who are very sick. So it's that kind of outsource. It's not as a substitute as it's sort of an adjunct, so that the physician can kind of have someone else do the background and then go in and to be able to kind of address more specific issues the patient and family caregiver may have. But it's not to say that the physician doesn't speak at all, because I think one of the issues was that time was a big limitation in the for the physician to do as thorough a job as he or she may want to do. So using other people to be able to share information and share prognoses may be something that some healthcare systems may be able to do. Not every system. And again, it's not appropriate for every patient as well. Does that clarify it?
Somewhat. And, I guess I just, I mean, that, was wondering, what the thinking was of outsourcing. You briefly explained that, but my feeling is the more the communication or something gets lost. I know my own personal scenario with my mother, not recently, but in the past, as to speak of, ICU and my dad many years before that. I wanted to speak to the doc. And, COVID has changed medicine tremendously. And, physicians and nurses, the clinicians care, but along with care, I put the word patient-centered care, as you mentioned, first. And that whole umbrella, patient-centered care. So that gets lost, and many healthcare systems don't even use the words. So thank you for the fine work you are attempting and trying to do here. Appreciate it greatly.
And I think, Glenna, too, that structure is really interesting and alludes to a chat comment that came in from Grace. They said that the health team should have a pointed person to communicate with our message and recommendations to the families, because on the receiving end, as a patient's family, they were visited by palliative care, pulmonary specialists, so many different people, which didn't come off as empathetic and made that communication unbearable for this individual. So I can see how a structure like that could be supportive.
Thank you very much.
Well, we are just about at the top of the hour, and I just want to again extend my immense gratitude to Dong and Glenna, not only for your work on this project, but for the tireless work you've done all year and through this pandemic. I mean, for the rest of you, meeting with these two every other week was just such a lens into the pandemic and the front lines, and they show up every day just like their colleagues, and I'm grateful for both of them and everything that I've learned being on this project with you. So thank you very, very much.
Well, thank you for those kind words, and also the opportunity to share some of this work. And we love your comments and insights, and this will really be really just amazing things for us to think about moving forward.
Well, Thank you so much to all of our presenters today, especially Dong and Glenna. Thank you for all that you do and even taking the time out of your extremely busy schedules, I know, to share this information with us. We're really excited to view the final report, which will be out very soon. But with that, I would also like to thank everyone who joined us today and wish you all well and hope you are all staying safe. So thank you so much. See you next month.
Thanks, Lindsay.
Thank you. Bye, everybody.
Thank you, everyone. It was great.
Thanks,
Both
Rosie.
doctors and Libby and Lindsay. Great, great.
Thank you.
Lindsay or Glenda, hear me? This is Nancy Brackerman.
Hi, Nancy.
Yeah, bye, Nancy.
I'm sorry I was